this the correct way for a patient? Nope. There we go. So knees flexed. You will have already flexed them whenever you do the popliteal. So just leave them once you do the popliteal pulses. And okay, so we're going to use our light again. Inspecting the abdomen. And so my verbiage as I'm inspecting.
No discoloration, lesions, or scars. Contour is flat with visible aortic pulsations.
So then again, coming over to your patient's right side, so we're gonna also, I don't even have my stethoscope. I think I left it up here.
You can feel my constipation.
Oh. We got that in 4K, by the way.
Life is struggle.
Caught on iPhone.
Okay.
Saw
So
it on iPhone.
what areas are we auscultating?
The 4 quadrants and the epigastric.
In the epigastric, right. So I would say go a little bit, yep, right there, perfect. So basically, because the divide is here, so you want to make sure you hit all 4 quadrants. And then we're just lightly with the diaphragm, listening to the 4 quadrants. And then the epigastrum. For a reasonable amount of time. You don't want to be like, but just enough to like, okay.
Are you hearing normal bowel sounds?
Mm-hmm.
Normal active bowel sounds.
And then we're percussing. So this one we percuss 4, all 4 quadrants, and what other ones?
Liver.
Bladder, stomach.
Yep, the stomach, and then,
Bladder.
yep, so down here. And then yes, the liver after we do that. So just go. So you notice those kind of, there was variant just based on what's going on in there. But it's all still normal. You should either, it should be tympanic or it should be dull. Okay. And the stomach. Okay. And
No discomfort or large areas of dullness.
all right, so now we're going to estimate. So what they usually have you do, or you guys usually do, you'll have your patient hold a marker for you, and you can put this kind of down here, have the patient hold the marker. So hers is going to be difficult to get to the right mid-clavicular line. So try to have, which I don't know if you can do that both at the same time, so I'll leave that here. So displace your tissue laterally. Yep. And then, well, you can relax for a second because we'll do this one first. So starting in the right, right lower quadrant, then you're gonna move up towards right here because we know it kind of hides right under there, right? So mid-clavicular line, you're starting that same area. And so you're going to hear the difference once we get to the really kind of dull portion. So hers probably right about here. And then we'll make a mark. Don't lose your spot.
It's like a tattoo.
Yeah. There, it's hard to get off. You essentially have to like scrub your
We
skin.
have alcohol wires.
Yeah. Good luck.
We'll just tattoo.
All right, so now I'll have you displace your breast tissue for me. Okay, and then so you can kind of angle. What I'm doing is like angling like that. Obviously, I don't want my hand to be on her. Only one finger should be on. And then lift up. Yep, just lift up. Yep, perfect. So you're still staying within that mid-clavicular line.
Oh yeah, I know, all those chairs.
Yeah, so you can tell that that's different.
liver. Old people be eating.
Okay. So make sure you're using the centimeter slide, guys. And then hers is about 7, which is normal. What is our normal range?
6 to 8, 6
Yep.
to 12.
So
6 to 12.
liver size estimated at 7 centimeters at right pubic line.
Yep, but you'll actually, that's another one that you'll read out. Because if we're like, that seems weird, we're gonna go back and percuss after the exam. So that one you will actually report. So now we move to palpation. Again, so 4 quadrants, 1 hand, light palpation. Sorry, move that. So just going. Okay, and then,
No tenderness, guarding, or rigidity with light palpation.
okay, and then deep palpation.
No tenderness, guarding, rigidity, or masses with deep palpation.
Okay. And then we're going to palpate for rebound tenderness. So when I press down, when I lift off, just let me know if that's painful. Okay.
No rebound tenderness.
Alright, and then we're going to do the palpate for the liver edge. So again, just firing off. Okay. So you're gonna put one hand underneath, so right there, and you're basically going to be pressing up, so trying to push that liver forward. Then you're gonna use the side of your hand and then just angle it along the side of the rib cage, and take a big deep breath in for me, and then out. And in one more time. And then out. And so you should feel it. It's very subtle, so you don't want to squash down, but you should feel the liver edge just kind of graze and come under, or come against your hand.
Liver edge is smooth and non-tender.
All right, and then so for the Murphy's, same thing. You're gonna want to put underneath, and then take a big deep breath in, and then out. One more deep breath in, and
Oh shit! Sorry about that.
but you do want to do that quick jab, but it is uncomfortable regardless.
It scared me.
Murphy's test negative.
Positive.
Murphy's test negative for cholecystitis.
Right. And then for the spleen, so same thing on this side, kind of pushing forward, aiming it usually sits kind of right there, and just in here. And then I don't think, do we have them breathe for that one?
Doesn't say so.
No, I don't think so. You're just trying to feel, basically for that one, you're trying to feel the spleen. You're trying to feel if it's enlarged, because it's very hard to palpate the spleen. But as far as like, if it's enlarged, you'll feel it, and then that's abdomen.
Spleen is non-tender and not enlarged.
All right. And so then the abdominal aorta. So for this one, I'm doing it on this side because it's going to be coming down to the left. And let's see if we can see. You don't have to use the light. I'm just seeing if I can see her aortic pulsations.
So,
Yep, you can see hers. It's like right here. So do you guys all see? Yep. And so you'll just go and try to trap it. And then that one you can just say estimated at 2 centimeters is fine.
abdominal aorta is estimated at 2 centimeters wide without lateral expansion
So you
of
said
pulsation.
Yeah.
So we find it, and you said we kind of walk it out a little bit just to make sure it doesn't spread out past that.
Yeah, I mean, really you're kind of coming in. So the pulsations, you're really looking for those as far as like if it's not just anteriorly and it's coming that way and you see it like more than 2 centimeters, okay, or 3 centimeters, then you're concerned.
Okay.
And then if that's the case, I'm not gonna touch it. I'm gonna get imaging. But yeah, so for this, you're just coming here. You wanna kind of, I always look down so I can see it better. It's much easier to see that from this angle than from a looking down angle. But hers is just easy to see anyways. And then you just trap it and then your measurement. And then, all right. So for the psoas, it's just internal hip rotation. So bringing it up, just like when we do our exam, and yes, and internally rotating. And then a positive would be pain in the right lower quadrant.
Ooh, and you still say flex for that one?
You can keep that one flexed, that's fine.
Okay.
Doesn't really matter. But
So
yeah.
in the thing is a supine knees straight, knees plural. So
sure. I guess because of the psoas, because they're going to be straight for this portion, and they're like kind of combined. Yeah. So sure. But if that one is still up during it, I don't care. Like you're examining the right leg anyway. And then so lift up against me. Okay. And then positive sign would be pain in the right lower quadrant.
So for psoas, negative psoas, and then obturator, negative obturator.
Okay, and then the last part, you're gonna sit up. And we're gonna check for CVA tenderness. This is one of those things I think we all do a bit differently. I place my hands and then hit. So you're doing CVA is that costovertebral angle. So meaning where the ribs hit the vertebrae. So it's usually right about there. And if they have pain, then that can be a sign of pyelonephritis or kidney infection.
No CBA tenderness.
Okay. And that's it.
Cardio.
Any questions?
No, I don't use cardio.
Nope.
It's upper extremity.
All right, go for